Good afternoon, everyone, and welcome to today's Hopkins Hour online seminar. The topic for today is Personalised Assistive Technology, Latest Evidence and Applications. I'd like to extend a warm welcome to all of our Hopkins Centre members, partners and collaborators who are joining us today. Before we begin today, I would like to acknowledge the traditional owners of the land on which we meet virtually. My work office is on the land of the Jagera and Turrbal peoples, and I'd like to pay my respects to the elders past, present and emerging. For those of you who don't know me, my name is Tamara Ownsworth. I'm the Research Director of the Hopkins Centre, and it's my pleasure to be chairing today's online seminar. In just a moment, I will be handing over to our first speaker, Professor Louise Gustafsson, who will also be moderating the remainder of today's event. We'll then hear from our next speaker, Dr. Jessie Mitchell, for a second presentation. And I'm also really pleased to introduce our panel members, who include Camilla Sharota, Janelle Griffin, Emily Gibson, Genevieve Lee, and Hayden Boyd. And they will be joining us today at the end of the session for a panel discussion on our topic, as well as for question and answer time. So just before we begin, I'd just like to run through a few housekeeping items with you. We know that internet connections vary in the online environment, so if you experience technical difficulties, please feel free to put a question in the chat via the toolbar at the top of your screen. One of our events team will do their best to assist you, and if needed, we know sometimes that leaving the Teams event can help and then rejoining. For those of you who'd like to use captioning, we have real-time captioning available via the URL link that our events team are putting into the chat now. This link was also included in the email that was sent out yesterday afternoon about the Hopkins event. We're very keen for people to ask questions at any time throughout today's event. So although the presenters won't be able to address them at the time, we will be monitoring and keeping check of all of the comments and questions that have been included. So please use the Q&A function. So again, that's at the top of your screen where you see Q&A and two little thought bubbles. So please click on that box on your screen and enter your comments and questions. If for any reason you can't access the Q&A, please feel free to raise your virtual hand by selecting the raise hand function in the navigation bar, which is also at the top of the screen. So Louise, who is moderating, will invite you to ask your question, and remember to unmute yourself before you ask your question. So all questions will be moderated by our events team and addressed towards the end of the presentation. We'll do our best, or the presenters will do their best, to answer as many questions as possible. If for any reason we don't get to all the questions, these will be responded to after the event via email. It's now my pleasure to introduce Professor Louise Gustafsson, who's the moderator and first presenter. So Louise is Program Leader at the Hopkins Centre for our Enabling Technologies and Environments program, and she is going to present on the Growing AT Solutions in Queensland project. Welcome and thank you, Louise.
Thank you, Tamara. It's really exciting for me to be able to present for you today, I guess, an overview of this project that ran from the end of 21 till 22 and really was looking at the assistive technology sector in Queensland. I am, of course, not the only person who was involved in this project. Hannah, could you please swap the slide? I am presenting on behalf of a fantastic team today that includes a range of researchers, people with psychology backgrounds, occupational therapy backgrounds, and rehab engineers. So quite an interprofessional team that I'm presenting on behalf of today. I also need to acknowledge that this project would not have occurred without the partnership of NIISQ, and we're very grateful for their support with this work. And it's really important that I state that I know I speak on behalf of the research team when I say that none of us position ourselves as experts in terms of assistive technology. So we're very grateful to the members of our advisory group who represent AT experts, expert clinicians, organisations that support people who use AT, and also very importantly, end users, people who use assistive technology, who met with us regularly and guided us throughout all of the project. A very, very quick background to this project. We all know that there's been significant reforms in the disability sector, and a couple of things have happened in response to that. Quite an expansion of the workforce, and we've seen quite a proliferation of new businesses or professionals who are working now in this community space. Equally, this is happening in the context of a time when technology is rapidly changing, and even mainstream technology that we know can be used to support people to achieve their optimal levels of community participation and involvement in their occupations. So there are many questions asked about how are people keeping on top of these changes, how well prepared is our workforce to work in this rapidly expanding space. And so the decision was made to run a full needs analysis of the AT sector in Queensland. So the project objective overall was to really get a clear understanding of what the AT sector in Queensland looked like over that 12-month period. And this could have included looking at barriers and enablers, but certainly also identifying pressure points and identifying possible solutions. An overview of the project, we feel it ran in these 4 phases. So phase 1, we were looking at normative and comparative need. And in this phase, we were looking at auditing the websites of the agencies, schemes and regulatory bodies that managed funding or supported the process of people obtaining assistive technology. And then we also conducted interviews with 11 representatives from 10 of those agencies and schemes. Now, that involved, at that point, we removed the organisations that were more regulatory bodies, so they didn't participate in interviews. We had intended a comparison of normative and comparative need, but as often happens when you set into a project and you start thinking more deeply about what you're doing, we can say that there were 3 organisations in Queensland that we considered the normative need, 11 comparative from interstate, and then there were 3 national organisations as well, which initially were going to go into the normative Queensland results, but we recognised that that was then skewing the results, as they should have also been included in comparative. So you can see that national sneaking in there. The second phase of the project was looking at expressed need. And here we were talking about the people who were working in the system, the people working between the organisations and collaborating with the end users or the recipients. We ran an online survey at the same time as many other surveys, unfortunately. So our response rate for that was below what we were hoping for and anticipating. So we're hoping that the other organisations that were running surveys at the time got good responses. But we had 29 people respond to us in full. And from that, 12 people nominated to also be contacted further for focus groups. When the focus groups ran, we had 9 people who then actually attended. So I ran 3 focus groups with 3 people attending in each focus group, and they were representative of a wide range of professions. We also, within this phase, conducted initial interviews with suppliers, so companies that provided the hire or trial or the purchase of equipment and would have been involved in these processes with the advisors and the end users. At the same time, we were running a third phase of felt need, where we wanted to understand the experience from the recipients or end users' perspectives. There are online surveys to which we received 41 responses. And again, people indicated if they were happy to participate in interviews, and we had follow-up interviews with 20 assistive technology recipients. The final phase of this project, which ran in August of last year, was a solution building workshop. And this included all of our advisory panel, as well as additional key stakeholders that we had identified along the course of the project. So we all came together for a day and we presented them the findings for each of these phases and some overall outcomes, or what we identified as pressure points. Sorry, I'm going to step back for a minute. And then we ran through the day, and the focus of that day was for the group to generate priorities from those findings and also potential solutions to build a body of work that we would continue along. There were some clear frameworks and models that we positioned this work in, so I just wanted to make that clear at the start of this presentation. This AT consumer pathway, you can see here from De Jonge et al., is a pathway that promotes the full what we see as best practice when someone is seeking assistive technology to find solutions to meet their needs. And this covers these 4 steps of imagining. First, imagining what life could be, what might be possible with assistive technology, and really starting to explore that potential for AT to achieve this, and setting goals for what they would like to achieve. The next step in this pathway is seeking information, so collaborating much more deeply about identifying and thinking about what potential solutions are, what is needed from the AT, and then also starting to think about what might we move towards trialling. The third phase is choosing, which is the trialling and really making some key decisions about what is best fit for purpose and what meets the need. And then obviously that process of applying for the technology. The final phase is the living phase, and this is the phase where people have received the technology, they've had the training, and the advisor is continuing to work with them to reevaluate and ensure that that technology is suitable and the best fit for what they are requiring and wanting to achieve, and most importantly, that their goals have been achieved. So that very much guided much of our questioning in the interviews and in the surveys, and in terms of some of the questions we were asking of people. Oops, sorry, somehow we have clipped back. Let me move forward. The next slide here is just presenting the 5P, People-Centred Assistive Technology Model, that's been published by the World Health Organization. There is obviously a lot of work in this space from the World Health Organization, and they are promoting the need for people to think about the assistive technology space through this model, saying that the people or the end users are always at the centre, and we need a very well coordinated and sustainable practice in terms of policy, the products, the personnel that they're working with, and the processes of how these are, the assessments and the provision of technology occurs. So again, this is something that we were constantly thinking about as we were working through the project and through the findings and what we were hearing. So when we think about the findings from all of the data, well, I'm not presenting the individual because there's obviously masses of that, we found there were 3 pressure points. The first pressure point sits around the transparency of information and the level of information that's available. And here very much we're talking about the information that's available from the agencies and the schemes. And certainly from the interviews, the people who were representing those agencies and schemes were very much identifying this as an issue. And for some, they were starting to action it and make changes to it. But we found there was very little information available about the process, about how decisions were made to inform the assessors and recipients about what was appropriate and not appropriate to be seeking. Sitting alongside that was the words reasonable and necessary. We heard them multiple times. There's recognition that how they are operationalised, and I guess when we're thinking about advisors or assessors who might work with clients from a range of different schemes, how those terms are operationalised can be slightly different, which can be confusing and can lead to delays or rejection of applications. But even within certain schemes, there was a sense that it wasn't clear exactly what they meant. And there was a sense that sometimes applications would go in that from the two individual perspective, from a clinical reasoning perspective, they were very similar, but one might be accepted and not the other. And it was felt that sometimes it was either around how these words were operationalised, but equally about whether there's some really key information that we're not aware of that's causing these delays in the process. And really people spoke to this quite passionately about it leading to kind of wasted time and process issues and rejections that perhaps could have been avoided if people were more familiar with the processes or the needs or the guidances. And also equally that when things are rejected, that has quite a significant impact on therapeutic relationship that results in additional delays. So it was quite a big theme, quite a big talking point. The second pressure point sat around the quality and quantity of advisors and assessors. Certainly there was a recognition that this rapid expansion of the sector had led to a rapid extension of people working in the sector, and certainly a lot of those people had very low level or entry level skills into what could be quite a complex area of practice. And so there was definitely a need that came from all of our participants to really find ways to help people to develop the expertise that's required to work within this system, to ensure that there's an individualised approach, that the voice of the recipients is being prioritised. And certainly the recipients talked about how this could really impact and influence their trust and confidence in the professional that they were working with, if they felt like it was kind of I've always done it this way, so we're just going to work this way with you. The flip side to that is that there are certainly examples and talk of how the people who are the experienced and specialist advisors in this space are perhaps less accessible to others working in this space with the changes in the sector, or equally that people were leaving the sector because they were finding the new systems difficult or disheartening to work in. So there was a sense of lost resources as a result of that, this loss of also what used to be specialist hubs that seemed to disappear with the introduction of the newer schemes and just haven't quite built up yet. And perhaps one concerning thing that came through with this is that therapists were telling us they were making decisions about who they would work with in terms of recipients. So if someone seemed too complex, they wouldn't accept the referral, but many people were doing that. So these individuals with complex needs were a little bit lost and flailing in the system, or that they were choosing to only work within certain schemes. So there's a lot that's happening in this space that we also need to think about and address. And the other big piece that fits into this, and I've alluded to this a little bit, is this loss of specialist hubs for people to come and meet with experienced professionals or specialists or trial equipment, and that's really problematic for the sector. But equally, it's problematic for the suppliers and the people who are supporting those trials, because there is theoretically there's very huge demand now around our huge state, and it is just really very difficult for a business to run in a way where they can have enough equipment available for them to be out for trial for huge lengths of time and still then keep the flow through of business. Equally, people are saying we can't access it to trial, so we're kind of recommending equipment with very limited information, so there's more room for error. The other thing that's happening there, AT graveyard was a term that we heard a lot. So a lot of equipment showing up on Facebook Marketplace and other places because it's just not quite fit for purpose. So people are getting rid of it, and perhaps the person who's buying it also isn't suitable for them. So it's really creating this flow-on effect. So when we look at the solution building workshop, quickly how we ran that, we presented the findings and everyone had opportunities to discuss and ask questions. And then later in the day, we had 3 rounds. We divided the group up into 4 groups, and each group sat and talked about what they'd heard from the findings and started to identify priorities from their perspective and possible solutions. After that first round, we brought 2 of the groups together. So we then went from 4 groups to 2 groups, and they each shared what they had discussed and prioritised with each other, and then worked with that combined list to again prioritise and develop solutions. And then finally we came together as a big group at the end of the day to develop a final list of priorities and solutions from the entire group. So the last slide is just really presenting some of those to you. So reminding you these were the 3 pressure points that essentially covered the majority of our findings. The number 1 priority and solution was that people with lived experience need to be employed to work at all levels in this space, and certainly looking at that level of governance and policy through to what's happening at the coalface and in these specialist centres. In terms of the transparency, keep moving through. In terms of the transparency and the information available, it was absolutely identified then as the next 2 priorities. We need to work on making sure that there is more information available around guidelines, decisions, and also pricing, so that when assessors and recipients are working together, they're very well informed about what they're deciding and what they're applying for, so that perhaps some of these delays and issues that are happening in the system could be rectified. There was discussion around perhaps this need for good practice guides or communities of practice. We're aware that these exist, so there's probably opportunities for better advertising of these services for people, but certainly looking for other ways for them to be delivered that perhaps meet needs better. People spoke about the need for assessors to really follow that full process that I introduced from before, from imagine through to living and evaluating much better. So what's required to support that to happen. We're looking at, therefore, building also expertise in the existing workforce, and perhaps undergraduate graduation as a way to do that, but we can certainly look at that in other ways. And then the final one was really around recognising that some of those pragmatic issues may not change, but perhaps we can look at a trial to buy pathway and improving that kind of hiring, trialling process in that way. So these were the solutions that were identified on the day. My contact details are here, so if anyone's interested and want to get in touch, please do. We've got 1 paper that is hopefully very close to being accepted for publication, and another 2 that will be submitted very soon, and a 4th one that we're about to start developing that talks about the whole project. But we're also looking at continuing this work. So the next step is going to be around starting to co-develop these solutions for individuals. So I'm going to finish up now, and I'm going to move to the next slide, and it gives me great pleasure to introduce Dr. Jessie Mitchell, who's going to present to you about their scoping technology project.
Thanks so much, Louise. I will be presenting today about a review, and Hannah, you might just need to take me back because I don't think I have control yet. A review that was a collaboration between some researchers here at the Hopkins Centre who are here today, and then also clinicians at the Brain Injury Rehabilitation Unit at the Princess Alexandra Hospital. Again, a few of who are Emily and Janelle who are joining us here today. And so this kind of review came out of a clinician-identified need to understand current evidence for the efficacy and use of electronic assistive technology, which we refer to as AT, in clinical practice. And so we recently published the review in the Journal of Neurotrauma. And so if you're interested in more details, you can find the information there for the full review. So in terms of memory and traumatic brain injury, memory is really often impacted by brain injury and is a significant source of frustration for people with traumatic brain injuries or TBIs and their caregivers and families. And there are a few different types of memory, including retrospective and prospective memory that are both influenced or negatively impacted by brain injury. So retrospective memory is around your past life events and things that you've learnt, whereas prospective memory is the ability to kind of form intentions and carry those out into the future. So there are a few different phases involved in prospective memory that'll be important later on. So I'll give you a brief overview. So if you think about a prospective memory in terms of remembering at 10 a.m. in the morning to put a chicken on to cook when you get home from work for dinner. So you've got to first form that intention, then you've got to keep that intention in your mind over time. You got to retrieve it when you do get home from work and then carry out the task. And then that evaluation phase is, oh, I actually remembered to prepare dinner as I intended. And so the inability to do this, kind of remember what it is that you want to do, your past life experiences, and carry out goals and intentions is really important to self-identity. And so after a brain injury, kind of experiencing issues in these ways can be really damaging to people's self-identity. So thinking now, sorry, I'm having a little bit of a lag with my slides. Thank you. All right, so there is considerable research that focuses on the use of assistive technology to support memory function, but previous reviews have concluded that there's a lack of reliable evidence to support the use of AT for memory. Now, this does not mean that it's not effective, it just means that there's not enough research being done to support it in clinical practice. And there's particular unanswered questions around how AT supports those different phases of memory functioning that I mentioned briefly before, and what influences use or uptake in daily life, which is really important for understanding how we can get people to first adopt the technology and then use it in an effective way in their lives to support their memory. And so what we're looking at with the review is to kind of, with these rapid technological developments out in the world, and then also in terms of the kind of lack of support of previous reviews, we wanted to update and do a more recent systematic review around the efficacy of electronic AT used by individuals with traumatic brain injuries to support memory function in daily life. And we're particularly interested in whether this evidence varies according to individuals' level of independence in using the technology to support each phase of memory. And then we're also interested in user perspectives on the utility of electronic AT and factors that might influence its use or uptake. So to give you a little bit of a look into the methodology of our review, we conducted the review in June of 2022. And we searched 6 electronic databases using a set of search terms around what we were interested in. So our population being individuals with brain injury, the intervention, looking at the use of electronic AT. And so when we talk about electronic AT, we mean things like smartphones, smart voice assistants, wearables, and then the outcomes in terms of memory. So whether people remember to do things and how that impacts their cognition in daily life. And so we identified 4,801 records to begin with, but after deduplication, that resulted in 2,721 to screen when we first screened the title and abstracts, and then took on a two-person review of the full text articles. And that left us with 19 eligible articles to include in the review. So looking at kind of an overview of the studies and what they looked at, there were 311 participants across the 19 studies, and they had traumatic brain injuries that were mainly moderate to severe and long-term. The devices ranged from kind of older technologies like PDAs and pages to more recent technologies like smartphones, wristwatches, television-assisted devices. And I should say that one of our inclusion criteria here was that individuals with brain injury needed to be independent in using the device, not throughout all phases of memory or all aspects of use, but at least in one aspect. So for example, maybe they needed to enter the reminder themselves, or decide on the scheduling, or retrieve the reminder themselves. And then in terms of outcomes, there was a range of self or caregiver reported memory performance. There was also things like recalls of reminders or frequency of technology use, and then completion of tasks. And they ranged from kind of self-identified tasks like medication taking to researcher-directed tasks like phoning in at a particular time and day. And so if I talk about kind of the types of technology and their efficacy, or the functions of the technology and their efficacy in terms of our first review question around what's the efficacy across different phases of memory and levels of independence. So there were 2 studies that evaluated people's ability to think and enter reminders, and those were both effective in the blue up the top. There were 9 studies in the green that evaluated people's ability to recall information to complete tasks that had been pre-programmed into the device by a researcher, clinician, or family member, and 6 of these study interventions were effective out of the 9. There was 3 studies in the orange that evaluated people's ability to remember to complete tasks when they were cued or supervised to enter the reminders into the device, and 1 of these out of the 3 was effective. And then in the purple, there was 5 studies that evaluated people's independence in using the technology across all phases of memory. And 3 of these 5 interventions were effective. So overall, there was, I think, 12 out of 19 that were effective or found evidence for the efficacy of AT to support memory after brain injury. So there's a few different kind of levels of evidence that we talk about in research, and the highest quality evidence comes from RCTs or randomized control trials, and that's because they're really good at controlling for factors that we're not interested in that might influence the results. So there was 4 of those included in the review, and out of the 4, 3 found support for the use of electronic assistive technology to support memory. So in terms of those 3, Limoncello looked at a device that attached to people's home televisions and provided an audio-visual reminder that kind of sat on their screens for about an hour before they were either able to indicate that they'd completed the task or suggest that they didn't want to, or that they'd like to delay the reminder for a period of time. And so there was higher task completion rates than typical practice, and 72% indicated that they continue to use it after the study or would be interested in doing so. I think, though, an issue with the technology is that it's not portable, so you really need to be home at the time that you needed to execute that task to receive the reminder. DAOs instead looked at the use of PDAs, and so looked at Palm and Microsoft PDAs in comparison to usual strategies and pen and paper aids. And they found higher task completion rates in both PDA conditions as opposed to that kind of typical pen and paper aid and usual strategies. And 75% chose to retain them. The Palm was preferable to the Microsoft PDA, and I think this was around a louder alarm function in the Palm PDA, which people found preferable. Lannon looked at PDA training over 8 weekly OT sessions. And they found that people were more likely to achieve their goals, their memory goals, with the PDA. And there were fewer caregiver-reported memory problems. However, they did note that in almost 20% of cases, caregivers need to support people to use the PDA, and nearly 1/3 required further support from caregivers between those therapy sessions to use it. But again, a relatively large portion were interested in continuing to use those devices after the study completed. The one RCT that didn't find support for the use of AT was run by Ashida, and they used a customized software for tablets. And they offered 2 weeks of training before 3 months of independent use. But they didn't find any significant benefits. And potentially this is related to the idea that 78% reported that the device was difficult to use, particularly in terms of portability, because that tablet is quite a lot larger than the phones that most of us carry around, and a lack of flexibility in the alarm features. And so I think this kind of highlights the fact that although they're developing a customized solution, there was no co-design or user consultation to kind of get feedback on some of those features that might have negatively impacted the efficacy of their technology. So we also had a second review question around looking at what impacts people's ability or desire to use electronic AT. And so using findings from the review, we developed a framework. So one component of that was general issues that impact people's ability or desire to use AT. And these related to things like prior memory aid use and familiarity. So some studies actually use participants' own mobile phones as part of the intervention, attitudes towards memory aids, and the device features. And I think this kind of fits into lifestyle fit as well, around how well the particular AT reflects individuals' values, lifestyles, and sense of self. So the idea that maybe you don't have a great attitude towards using or carrying around a tablet all the time, but you perhaps prefer a mobile phone because it fits in with your active lifestyle. Cognitive skills, learning potential, and style, which are obviously really important after a brain injury, and there's lots of work around kind of the best way to train or help people to learn new technology after a brain injury. And then the availability of support to use the device in the community. So, that help to either pre-program reminders or have caregiver support in terms of kind of navigating any technical issues and things like that. And so as part of the framework, we also looked at user and design features that affect the success of AT across individual phases of memory, and particularly prospective memory. And so what we found is there's particular issues or features that affect each phase in particular. So if you're looking at that planning and intention phase, a lack of motivation and interest can negatively impact AT use, as can difficulty remembering to set reminders, so thinking ahead. And so some technology has kind of reminder setting features. So at intervals throughout the day, you'll get a reminder to set a reminder. Also, in terms of lack of support to ensure that you've correctly entered a reminder, and then being able to check on those reminders as you're kind of keeping that intention over time before you execute it. So can you go in and edit it as your plans change, as your day, the schedule kind of changes over time? What that prompt to act looks like. Is it a sufficient cue? Can you hear it? Is it in a preferred way? So if you're a visual kind of person or an auditory person. And then in terms of executing that task, is the cue kind of sufficient to help you to disengage from whatever you're doing to execute the task? And then evaluation. If you're not successfully executing your intentions, you're less likely to use the device over time. And so I guess to conclude, 12 out of the 19 studies found support for the efficacy of AT for improving memory-related functioning after brain injury. But I think, we didn't put any time limitations on our search. And so some of those technologies that we evaluated were perhaps not commercially available now. And so really continuing that kind of research around the efficacy of AT, particularly as it relates to different phases of memory and independence of use. So most support was found for the efficacy of AT when reminders were pre-programmed by someone else, as opposed to the person who was using the technology to support their memory. And I guess this was a little complicated by the fact that the goals were not always the person's own, but were researcher set. But what we also found, particularly in terms of those factors that influence efficacy of AT use in terms of user features and design features, is that there's a lack of consultation and co-design with people who use AT to support memory after brain injury. And so more of this is needed to really understand the features that were required to support people. And then, so we're just encouraging future research to kind of examine some of those features. And there's work by Jameson and colleagues around this happening at the moment around custom technology like AppleTree. I think that's all for me now. So I will pass back over to Louise, who's going to moderate a panel discussion for us.
Thank you, Jessie. That was really interesting. Great to hear that all presented in full. I have the great pleasure of introducing our panel for our discussion today, and also fielding the questions and answers. So first of all, I've got some questions that I'm going to put to the panel, but I certainly encourage you all to pop your questions into the chat or into the Q&A function, because we will come to those towards the end of the discussion. Firstly, I'd like to introduce our panel to you. The first person on our panel is Genevieve Lee, who is the Director of Participant Care at the NIISQ agency and an experienced occupational therapist, particularly working in the area of with people following spinal cord injury. We also have joining us two experienced clinicians from the Princess Alexandra Hospital, Janelle Griffin, occupational therapist, and Emily Gibson, neuropsychologist. The other member of our panel is Hayden Boyd, who is one of our project partners, is a lived experience expert and one of our resident tech enthusiasts. And Camilla Shirota, who is a research fellow with a background in rehab engineering at the Hopkins Centre, and obviously Jessie and myself. So I'm going to put the first question to the panel. And if I may, I might put this to you, first of all, Genevieve, if I may. The first question is, how would you describe best practice for AT solutions? And I guess from your perspective, what does that look like?
Yeah, thanks, Louise, and thanks for having me today. Best practice principles for AT for me really is obviously, and you've touched on this already today, really being person-centred and driven, person-driven, that AT has a really positive impact on a person's health and social outcomes, so important, that it's goal-driven. And that, the parts of that goal-driven is comprehensive assessment, that goal planning, and having a really clear understanding of the why, like why is the AT required? What is the problem and what does success look like? I think that's really, really important. Trial is a principle that we've already touched on today, and ideally in the environment where that AT is going to be used. And goal attainment. Like and the evaluation, which I'm so glad to hear people talk about already today, was the AT goal met? And not just on the day that it's delivered and set up, but, 4, 6 weeks, 12 weeks down the track, has it actually helped the participant meet their goals or the person meet their goals? And implementation principles, I think, are really important. And we've touched on that today already. The training and the setup and the post-evaluation, I think, is really, really important. And the other one is capacity building. And we see that a lot. A real need for this is that empowerment, being empowered with knowledge for the person, that they know, who do I go to solve any problems or issues or concerns that come up? And what are the maintenance needs? What are the repair needs? All of this information, when, who, and how. That bit we often see is being missed a little bit, and people are, lost when that information comes up. Who do I go to? And that peer support and networking, I think, is really important for the person with the AT and lived experience. So they're probably the main principles that I see.
Brilliant, thank you. I'm going to shift it a little bit for you, Camilla, because I know a lot of the work you do is in designing an AT solution. Would you add anything to that from that perspective?
Yeah, I totally agree with what Genevieve said. I think it's came through in the presentations today. I think the other thing to add is technology isn't always the solution, and the high tech also isn't always the best solution for everybody. So it's working through those goals and really seeing what people are comfortable with and how we can best really exploit technology to get closer to what the person wants to achieve. I think that's what we should keep in mind, and not think that, you know, the shiniest is the one that's going to get the best outcome. That's not always true.
Great. Hayden, from your experiences, would you add something to that?
Yeah, I think that personally, like something like a peer support in terms of having somebody with lived experience or in terms of similar disabilities who understands the needs of the person receiving the AT, having people like that who have prior knowledge, who are easily accessible for people, for AT receivers. I know that especially when I was coming through hospital, I heard a lot from clinicians, and it's fantastic with the information that they know. But hearing it from somebody who had a similar level of injury to me, who had practical application in their environment, I found was effective for me in applying that to my own lifestyle as well. So I think that's a big part of that for me.
Right, thank you. And it always feels unfair coming to the last people on a panel when there's been so many great responses and to the question already. But I'm wondering, Emily and Janelle, what you would add to this?
You can go first. Okay. No, I think great answers already, and we would say from a clinician perspective, making it patient-centered and goal-driven to help these people achieve their functional goals is the most important thing. We may initially get family involved initially to help that uptake when they're starting to learn to use a new device or app, or but then we gradually, you know, wean that to get the patient to then take ownership and use that more independently. And certainly it would always be about, that trial and review and problem solving any issues that come up, just to see how we can tweak it to make it work for them.
And certainly while our patients are most comfortable using the devices that they're already familiar with and that they have that practice effect on, we encourage them to be open-minded though, because if they've established a goal and targeting a goal, there could be a new AT device to consider. So we just encourage them to keep an open mind and a willingness to try something if we feel it could work to their advantage.
Because it can be quite scary, just the thought of it, can't it, for some people?
It can all be very overwhelming.
And it's all new. Yeah, I love it.
Especially, dare I say it, in the older age bracket as well. We find that a lot of our younger patients are more savvy and comfortable in using AT and more willing to try new devices and adapt it to their everyday activities, where a lot of our older patients aren't as flexible or willing to try something new or have more difficulty learning something new. So it's, as everyone has said, it's about the individual and targeting what that person's goals are and how to best achieve them.
So there's this real focus on personalisation of AT, and this question maybe is for Jessie, and certainly Emily and Janelle and others could probably speak to this. How do you think the framework of factors influencing the use and uptake of AT for memory might guide the personalisation of AT in clinical practice? Maybe to you, Jessie, first.
Yeah, I think, it's interesting, all those factors that we talked about around how AT fits in with people's goals and their lifestyles and who will be supporting them. We talk about them generally, but I think some of those factors that we found in the review, the way to operationalize it in terms of what the task you're actually doing is and what you're actually looking for support in. And I think also something to consider in terms that kind of Hayden initially brought up is like, does that change over time? So just because you find a great piece of tech to start with, is that the right piece of tech for you over time? And Louise, you kind of brought it up in terms of that concept of an AT graveyard.
Yes.
And how do we make decisions and support people to assess whether that technology is right for them across different phases of their life. And as things change, our memory changes, what we need to remember changes. And so looking at some of those user features around what your motivation is, how that technology fits into your life, how it fits into your self-identity, I think is really important too. Like how you want to look and how you want to present yourself to the world is important regardless of who you are.
Fantastic, thank you. Would anyone like to add anything to that? I am going to there's a question in the chat that's a little bit related that's going to bring me to you, Emily and Janelle. So I might ask that and feel free to answer the previous one. The question is really saying I'm wondering what AT you are finding that your young adult population in Beru are most keen to use, and that's from Simone.
Janelle and I just had a quick chat. It was definitely phone.
Hands down.
Their smartphone is
Yeah.
one of the main things that they're using. Sometimes the smartwatches, if they have them. Yeah.
But definitely, and as I said earlier, it seems like our younger patients are born with a phone and they know what they're doing, and they're teaching us a lot of new things on their phone, but that's the device that they're most comfortable with. That's the one that they're proficient in using, and that's the one that they're willing to try, because it doesn't look like it's not labeling, is it? It's not seen as an assistive device for their brain impairment as such. It's an everyday device, so it's very covert and they can use it successfully, and they're very happy to use it. So it's the phone.
Yeah, and there's so many good apps on there.
Absolutely.
Hayden, what would your experience be? What would you think?
Yeah, definitely. I mean, I sort of push people into smartwatches. I've got my own, and they're just handy. I'm lucky that I've got a phone mount on my wheelchair, so I can also have my phone. But for somebody in, let's say, a manual wheelchair, where they can't always have their phone within an arm's reach, watch is always super easy on the wrist. So yeah, those would definitely be the two most common that I'd come across.
Perfect. I know, and this probably comes into the next one a little bit, and I guess Genevieve, I'm wondering, I mean, we can think about AT and technology in terms of what's maybe on our phone or on our smartwatches, but there's certainly other quite high levels of tech that allow environmental control and other aspects of our, people's lives. What would you say is the experience of that, and what advice would you give to someone who is perhaps a little bit unsure of it?
In regards to their access in the home with that AT?
Yes, or more broadly, whatever,
Yeah, I think an important part of that for someone, if they're looking at AT solutions, is to make sure, one, I think the peer support is really important, and that's what we're hearing from our NIISQ participants all the time, and what they really value is talking to people with lived experience. I think I would really encourage someone, and we find our participants do that initially before they even come to us with with an idea of what they'd like. The other important thing then is to make sure that you're working with an AT assessor with the skills required to help them, just making that right match, because not everyone has the same level of experience or skills with AT prescription, and it might be the type of equipment, or it might be the environment, or it might be the type of injury that the person is living with, that they need to have those skills. So that skill match, I think, is really, really important. The other thing I would advise people is go out and do your research and make sure you are being your own advocate, is what I say to people. Like, don't rely on just the AT assessor. It is for you. So please go out, research, have a look, see what's out there, and come back with some of your own solutions, and be driving what you need to help you, have a great outcome and a great life with what you want this AT to help you achieve. So I think that is really important. And trial, really, really trying to, I know there's so many challenges, and we've already touched on those in the sector at the moment. but if possible, trial. It is really hard for our participants who are living in rural and remote to have that opportunity. So we're really trying to come up with some innovative ways to help them, because that makes a huge difference. We certainly have people coming down to Brisbane and doing it, but if you're living in Longreach or out at Winton, it's not the same experience. So that's the other thing that we really try to advocate and see, you know, and looking outside the box, how we help them do that.
Great. I have a question here specifically for you, Hayden. Brooke has asked, can you share what supports and education is available for someone as a new user?
Yep. So as a general, I tend to go back to hospital and help out, learning or helping to explore different assistive technologies, at least the ones that I use myself for my uni and for my work. I help go back to hospital and I help people go through that and learn that. I know that from my experience, at least, the company who I get my supports through, Spinal Life Australia, they've got an assistive technology lab. They've got lovely people there who can help out. There's all services. I can't speak specifically for every kind of disability because I just have my spinal cord injury. There are services who offer the support for those kinds of assistive tech users in ways of learning what they could be using to change their life now, but also what's being developed in the future that they can look forward to.
Great, thank you. I'm just mindful there's so many great comments and questions coming through, and I'm going to apologise in advance that we can't get through to all of them, and it feels quite stressful to have the deciding vote about what I say next. But there is a big picture comment question here that I guess I would love to put to the panel. This is from Melissa, who says, I'm interested in the panel's thoughts on the issue of what is considered reasonable and necessary, and by who. Obviously, there are differing opinions between the funders, the therapists, and the consumers. And I guess, what are the solutions that exist to resolve this issue? Who would like to go first?
Would you like me to go first as an
agency? I would love you to, thank you.
Yeah. I think what we can do as an agency is try to have really clear, and I think this came out in your research, Louise, and a lot of great takeaways, really clear guidelines as to what an agency like NIISQ, and it's different to other agencies that are out there, but in this, what the agency isn't able to fund, or those guidelines around treatment, care and support for us as a NIISQ agency. I think that's really important that we have those and that they're visible and that we are open and communicating with not just our what we call a NIISQ participant, but also the clinicians. So it's really clear right at the beginning of any conversation so that they have an understanding. And also if it is something outside of what we can fund, having that role in linking them with if there is another appropriate funding body. But definitely I think for us, we've got a remit to make sure that it's really clear at the start, and that's definitely what our participants are saying to us. We just want to know so that we're making informed choice.
Yeah, great. Thanks, Genevieve. Would someone else on the panel like to offer some thoughts here?
I think getting people, which I aligned with this when we did the research, or the research task that final day, getting people with disabilities into the I suppose the circuit, for lack of better words, in my head at the moment, getting people involved with the decision making, the understanding, giving them a voice of reasonability, because people who know what's going to work for people with disabilities is people with disabilities. So I think that that's a big part of what I presented in giving a solution.
Yeah, and that's great. Thank you. And that feels like a wonderful point for us to finish the panel. And I'm sorry we've run out of time. We could probably keep talking forever here today. But I would like to very much thank our panel members for your time today and for contributing to the discussion, and for all of you who have posted questions. Apologies that we haven't got to all of them within the session. I'm going to hand over now to Tamara, who is going to finish us off for the day.
Thank you, Louise. Very difficult to top that, and fantastic to see this topic generate so much interest. We invest a lot of research in technology and personalisation and co-design of technology at the Hopkins Centre. So if this is an area where you share a similar passion, we really urge you to get in touch to see if you're interested in collaboration. So I just want to thank all of our speakers and the panel members today for such a thought-provoking and clinically applied discussion, and also thank everyone here for attending today's Hopkins Centre. It's really exciting to hear about the developments in evidence and practice that are occurring both locally as well as internationally. We hope you found today's session informative, and if you would like to get in touch with any of the presenters from today, we encourage you to do so. So feel free to contact the Hopkins Centre email, hopkinscentre@griffith.edu.au, to connect or request documents shared today. Thank you once again for your participation, and we look forward to seeing you at the next Hopkins Hour, and have a wonderful week. Thanks, everyone.